Welcome back to the teaching service. Today we take cirrhosis into its late stages. We will cover hepatocellular carcinoma and how to screen for it. We will separate hepatopulmonary syndrome from portopulmonary hypertension. Residents mix those two up constantly. We will run through the complications that quietly harm these patients. And we will finish at liver transplantation. Who gets evaluated, who is excluded, and how they do afterward. One patient will carry us the whole way through. Here is our patient. Mr. R is 58. He has cirrhosis from hepatitis C and years of alcohol use. He has been abstinent for 14 months. His model for end-stage liver disease score, or MELD, is 16. He came in for a routine visit. Then he mentions something new. For 3 months he has been short of breath. And here is the detail worth catching. It is worse when he sits up, better when he lies flat. Hold on to that. We will come back to it. 8 objectives. First, the cancer. How big is the risk, and what makes it worse? Then the surveillance protocol you should be able to recite. Next, the 2 pulmonary syndromes of liver disease. We will define each one and give you a way to tell them apart at the bedside. Then the complications that get missed on rounds, the heart, the vaccines, and the coagulopathy that residents consistently mismanage. We finish with transplant. When to refer and who is excluded. Take the history apart. The dyspnea has built over 3 months. It is worse sitting or standing, and better lying flat. Notice that this is the opposite of heart failure. There is no orthopnea, and no waking up short of breath at night. His exercise tolerance has collapsed. He used to walk the neighborhood, and now the mailbox stops him. Nothing points to infection. No fever, no chest pain, no black stools. So this is not decompensation from a bleed. Now the background. Read this list as a risk profile. Treated hepatitis C, cured virus. But the cirrhosis and its cancer risk remain. Alcohol, diabetes, tobacco. Every one of those raises his risk of liver cancer. And look at the last line. His surveillance ultrasound is 11 months old. It should have been done at 6. That single line of the chart is the most actionable thing on this slide. The exam is where this case turns. He is clubbed. He has spider angiomas across the chest. Both of those belong to chronic liver disease. Then the vital sign that makes the diagnosis. His saturation is 96% lying flat. Sit him up and it falls to 89. His lungs are clear. There is nothing to hear. The abdomen is soft with only trace edema and no asterixis. So the lungs sound normal and the oxygen is not. Before we chase the breathlessness, we owe him a surveillance scan. So start with hepatocellular carcinoma. This is the complication that turns a stable patient into a terminal one without ever announcing itself. It is also the one where what you do in clinic actually changes the outcome. Start with the numbers. Cirrhosis of any type carries a 1 to 6% risk of hepatocellular carcinoma every year. That is per year. It compounds. Add chronic hepatitis B or C, and the annual risk climbs to roughly 3 to 8%. Now the line that should change your behavior. Hepatocellular carcinoma is the leading cause of death in cirrhosis. Not bleeding, not confusion. Cancer. Which makes surveillance the highest yield thing you do at a cirrhosis visit. And notice what is missing from this slide. A cause. Every cirrhotic liver carries the risk. Not only the viral one. Any cirrhosis is enough to screen, but these push the risk higher. Viral hepatitis B or C. Alcohol on top of the liver disease. Obesity-related fatty liver disease. Hereditary hemochromatosis, diabetes, and tobacco. Now count them in our patient's history. Hepatitis C, alcohol, diabetes, smoking. 4 of the 6. His virus is cured, and he has been abstinent for over a year. But a cured virus and a sober year do not undo the risk that history already built. He is exactly the patient the protocol was written for. Follow the 3 branches. On the left, nothing. The patient feels well, and the tumor is found only because somebody ordered the scan. That is the most common presentation. In the middle, a patient who was stable suddenly decompensates. New ascites. New confusion. Ask why. On the right, portal vein thrombosis. And when a cirrhotic patient clots the portal vein, look carefully at that clot for tumor growing inside it. Memorize this. Step 1. Every 6 months, every patient with cirrhosis, indefinitely. Step 2. Ultrasound. With or without alpha-fetoprotein. The ultrasound is the backbone of the program, and the blood test rides alongside it. Step 3. When ultrasound will not do the job. Body habitus. A nodular liver. A poor window. Then, dual-phase computed tomography or magnetic resonance imaging is the alternative. Anything you find goes to multi-phase contrast imaging. One more point. Surveillance does not stop because the virus was cured or the drinking stopped. The scarred liver keeps the risk. Here's what the overdue scan found. A 2.4 centimeter lesion in segment 7. The magnetic resonance study shows arterial hyperenhancement with washout on the later phase. In a cirrhotic liver, that pattern is diagnostic. He does not need a biopsy. His alpha-fetoprotein is 68. One lesion, no vascular invasion. Treatment itself belongs to the oncology teaching. But hold this finding. It changes everything about his transplant candidacy. Now back to his breathing. There are two pulmonary syndromes that belong to liver disease. They sound alike. They are opposites. One dilates the pulmonary vessels. The other constricts them. Get them the wrong way round and every part of your plan is wrong. So we will build them one at a time and then put them side by side. Put the data together. His saturation drops when he sits up. He is clubbed. His lungs are clear. And his chest film is normal. So the problem is not in the airways or the parenchyma. His blood gas seated on room air shows an arterial oxygen of 62 and an alveolar to arterial oxygen gradient of 34. That gradient is the finding. Gas is not crossing properly. Now think about why posture would change that. This is hepatopulmonary syndrome. The posture finding has a name: platypnea, orthodeoxia, breathlessness and desaturation when the patient sits up. Here is why. The dilated vessels sit mostly at the lung bases. Stand the patient up and gravity sends more blood exactly there. So more blood bypasses gas exchange and the saturation falls. Clubbing and spider angiomas fit. The oxygen improves with supplemental oxygen. We confirm it with a contrast echocardiogram. Notice how this syndrome is defined. Not by symptoms, by gas exchange. Abnormal gas exchange means an alveolar to arterial oxygen gradient of 15 or more, or an arterial oxygen tension below 80. Either one qualifies. Then you need the other two pieces: liver disease and intrapulmonary vascular dilatations. All three together make the diagnosis, which is why a comfortable-looking patient can still have it. You have to check a gas. Pulse oximetry alone is not enough. A saturation can read reassuringly while the gradient is wide open. So in a cirrhotic patient with unexplained breathlessness, draw the blood gas and calculate the gradient. Follow the pathway. Step 1. Advanced liver disease with portal hypertension. Step 2. Vessels in the lung dilate. These are the intrapulmonary vascular dilatations. Step 3. Blood streams through those widened channels so fast and so far from the alveolus that oxygen never reaches the center of the stream. That is intrapulmonary shunting. Step 4. Hypoxemia. And notice the last box. It still improves with supplemental oxygen. This is not a fixed anatomic shunt. The contrast echo is a timing test. Agitated saline goes into a vein and the bubbles fill the right atrium. Now count cycles. If bubbles appear on the left within about 3 cycles, the shunt is inside the heart. A hole. If they appear late, 3 to 6 cycles after the right atrium, they took the long way around through dilated lung vessels. That is hepatopulmonary syndrome. Same test. The timing is the whole answer. Our patient shunted at 4 cycles. There is an alternative test. A technetium labeled macroaggregated albumin lung perfusion scan. It is less sensitive, so the contrast echo stays first. Treatment is short. Oxygen is supportive and it does help. If imaging shows one large abnormal vessel, embolization can be considered. A transjugular intrahepatic portosystemic shunt has been used in selected patients. And then the line that matters: liver transplantation is the only definitive treatment. Everything above it is a bridge. Notice what is not on this list. There is no drug that reverses the dilatations. So the moment you make this diagnosis, you are also making a transplant referral. It is also why this syndrome earns exception points, as we will see shortly. Now a second patient from the same clinic list. 46. Cirrhosis from fatty liver disease. 6 months of breathlessness on exertion, but no positional change at all. Her second heart sound is loud at the pulmonic area. Her neck veins are up. And here is the key contrast. Her saturation is 97% in every position. The echo estimates a right ventricular systolic pressure of 62 with a dilated right ventricle. This is portopulmonary hypertension. The definition is simple: pulmonary hypertension in a patient who has portal hypertension, with no other cause to explain it. And notice what is different. Her problem is pressure, not oxygenation. Her saturation never moved. The echo raises the suspicion. Right heart catheterization confirms it. And the treatment comes from the pulmonary hypertension world, which is a completely different plan from the last patient. 3 steps. End-stage liver disease and portal hypertension change what circulates in the blood. Notice the middle box. Endothelin rises. Endothelin is a potent vasoconstrictor. Follow the arrow to the right. The pulmonary arteries constrict and remodel, and the pressure climbs. Now hold this picture next to the last one. There the lung vessels dilated. Here they constrict. Same diseased liver. Opposite vascular answer. Treatment mirrors idiopathic pulmonary arterial hypertension, prostacyclin analogs, endothelin receptor antagonists, which makes mechanistic sense, given the pathway we just walked. And sildenafil. Then the important last line, liver transplantation is often curative. So like the previous syndrome, this one also drives a transplant conversation. The difference is that here you are treating the pulmonary circulation while that conversation happens. And unlike the last patient, oxygen is not the answer. Her problem was never oxygenation. This is the slide to remember. On the left, the vessels dilate. The patient is hypoxemic, gradient of 15 or more, or an oxygen tension under 80. Desaturates, sitting up, clubbed. Late bubbles on the contrast echo. On the right, the vessels constrict. Oxygenation is often normal. Breathless on exertion with a loud second heart sound and a strained right heart. Confirmed by catheterization. Dilate versus constrict. If you keep only one thing, keep that. One practical difference follows from it. Oxygen helps the patient on the left and does very little for the patient on the right. Acute-on-chronic liver failure. A patient whose cirrhosis was stable falls off a cliff. The teaching point is the second card. This is triggered. There is almost always a precipitant. Infection is the classic one. A return to alcohol is the other. So the third card is your move. Do not just support the patient and wait. Go find the precipitant and treat it. That is what turns the picture around. Cirrhosis has a cardiomyopathy of its own. The heart cannot answer a demand. Blunted contractile and heart rate response when the patient is stressed. Systolic and diastolic function are both impaired. The QT interval is long. At rest, the circulation is hyperkinetic and high output, so the patient looks fine. And both troponin and B-type natriuretic peptide run high, which is why those labs are hard to interpret in this population. Vaccination is real treatment here, unless the patient is already immune. Hepatitis A, hepatitis B, a pneumococcal conjugate vaccine, the 20 or 21 valent product on its own, or the 15 valent followed later by the polysaccharide vaccine, coronavirus disease, and influenza every year. Check this at a clinic visit, not during an admission. Cellulitis complicates about 20% of cirrhosis hospitalizations. Look at the abdominal wall and its swollen legs, and do not assume somebody else handled the vaccines. Check the status yourself. 2 endocrine problems ride along with cirrhosis. Diabetes is present in 15 to 30% of these patients. That is a large fraction, and it feeds straight back into liver cancer risk. Second, adrenal insufficiency is more frequent in cirrhosis than in the general population. So when a cirrhotic patient is in shock and is not answering fluids and pressors the way you expect, put the adrenal axis on your list. This is the one residents get wrong. Look at the left column. The liver makes fewer clotting factors. The platelet count is low. There is hyperfibrinolysis. Everything says bleeding. Now look at the right. The same liver makes less protein C and protein S. Profibrinolytic factors are deficient. And von Willebrand factor is raised. Everything there says clotting. The 2 columns offset. This is a rebalanced system, not a bleeding one, which is why the prothrombin time misleads you here. It measures synthetic function. It was never a bleeding risk score in cirrhosis. So here is the rule. There is no support for routine plasma, platelets, or cryoprecipitate in a patient with cirrhosis. Not for a number. The exception is disseminated intravascular coagulation. That is a different problem, and it does get treated. And do not swing too far the other way. These patients still clot. Portal vein thrombosis is a real event in cirrhosis. Rebalanced does not mean protected. It means unpredictable. So before you order products, ask 2 questions. Is this patient actually bleeding? And is there disseminated intravascular coagulation? If both answers are no, the products are not treatment. Nutrition is not a side note in cirrhosis. Screen for malnutrition, sarcopenia and frailty. Muscle mass predicts how these patients do. Monitor and supplement the fat-soluble vitamins. and zinc, then the number to carry. Protein intake of 1.2 to 1.5 grams per kilogram per day. Notice the direction of that advice. It is more protein, not less. If you were taught to restrict protein in liver disease, retire it. In practical terms, a 70-kilogram patient needs roughly 85 to 105 grams of protein a day. 3 rules you can apply tonight. Acetaminophen is allowed in cirrhosis, cap it at 2 grams per day. It is the safer analgesic here, not the forbidden one. Aspirin and the non-steroidal anti-inflammatory drugs should be avoided, and aminoglycosides are contraindicated. When you are asked for something for pain in a cirrhotic patient, this slide is the answer, and the reasoning is worth carrying. Non-steroidals threaten the kidneys and add bleeding risk in a patient who has neither to spare. 2 grams of acetaminophen is the safer choice. Now the last section, transplantation. Residents often treat this as somebody else in the hospital deciding. It is not. Recognizing the trigger and starting the conversation is a resident-level skill. So let us cover when to refer, what counts as an indication, who is excluded, and what the operation actually buys the patient. The trigger is a number. Undertake transplant evaluation when the MELD score reaches 15 or higher, but some patients are far sicker than their score says. So exception points are added. They are granted for hepatocellular carcinoma and for hepatopulmonary syndrome. Also for cholangiocarcinoma, cystic fibrosis, and transthyretin amyloidosis. Now look at our patient. A MELD of 16. A new cancer. And a pulmonary syndrome. 3 separate reasons to refer him today. Waiting adds nothing. Group the indications. The first 3 are complications of portal hypertension that will not stay controlled. Recurrent or severe encephalopathy, refractory ascites, recurrent variceal bleeding. The next 3 are organ syndromes, hepatorenal, hepatopulmonary, portopulmonary, then cancer within size limits, no single lesion above 5 centimeters, or up to 3 lesions with the largest 3 centimeters or less. And finally, acute liver failure. Notice the pattern. Each of these is a complication the liver will not be talked out of. Contraindications come in 2 families. On the left, the person and the setting. Inadequate social support, active substance abuse, with some exceptions, persistent noncompliance, and uncontrolled human immunodeficiency virus infection. Note that carefully. Well-controlled infection is no longer a barrier. Patients on suppressive therapy are transplanted at experienced centers. On the right, the disease itself, sepsis, advanced heart or lung disease, cancer outside the liver, cholangiocarcinoma, hemangiosarcoma, and acute liver failure, with a sustained intracranial pressure above 50. Now notice the difference between the columns. The left one is where a team can sometimes change the answer over time. These are the numbers to quote a patient. Survival at 1 year runs up to 90%. At 5 years up to 80%. For a disease that was going to take his life, that is a transformation. But the last number keeps you honest. Autoimmune liver disease can come back in the new liver. 10 to 30% of allografts. Or more. Transplant replaces the organ. It does not always end the disease. And it is not an ending for the patient either. It begins a life of immunosuppression and lifelong follow-up. Bring it back to Mr. R. 58, cirrhotic from hepatitis C and alcohol, MELD 16. He has a new hepatocellular carcinoma. A single 2.4 centimeter lesion, inside the size criteria. And he has hepatopulmonary syndrome. Oxygen tension of 62 with late bubbles on the contrast echo. Both earn exception points. He goes for transplant evaluation now. Meanwhile, oxygen, vaccines, a protein target, and a 2-gram acetaminophen cap. 6 ways this goes wrong. Letting surveillance slip. 6 months means 6 months. Calling the breathlessness deconditioning without ever checking a saturation sitting and lying. Mixing up the 2 pulmonary syndromes. Transfusing plasma at a number in a patient who is not bleeding. Restricting protein. And waiting. Watching a MELD score climb past 15 while the evaluation has not been started is the quiet one that costs the most. The recap. Liver cancer risk is 1 to 6% a year, higher with viral hepatitis. Screen with ultrasound, with or without alpha-fetoprotein, every 6 months. Hepatopulmonary syndrome dilates, portopulmonary hypertension constricts. The coagulopathy is balanced, so no routine products unless there is disseminated intravascular coagulation. Refer at a MELD of 15. And survival runs up to 90% at 1 year. These are the sources behind this session. The cancer surveillance interval and the imaging diagnosis, follow current hepatology guidance. The 2 pulmonary syndromes come from the dedicated reviews listed here. The nutrition targets come from the guidance on malnutrition, frailty, and sarcopenia in cirrhosis. And the transplant criteria and survival figures come from the transplant literature. Thanks for working through this one.